Yeah, we're pretty flexible here. We have an outline usually, and
Right?
then sometimes we'll go derail a little bit and then come back. And
Sure.
so,
If you haven't met me, that's how my brain works. So welcome
Yeah.
to.
Well, I'm similar too. So, I don't know, we could end up, who knows, like on the moon as far
yeah,
as I
right, right.
know.
Hello there. Welcome to the Good.Enough.Shrink podcast. We are your hosts. I am Jenna Chang, a child, adolescent, and adult psychiatrist practicing here in Los Angeles, California.
And I'm Dr. Patrick Kelly. I am also a child, adolescent, and adult psychiatrist practicing in the Los Angeles area.
We are on a mission to demystify child psychiatry and have conversations surrounding difficult topics on youth and adult mental health, but not without a little play along the way. Welcome back to the podcast. It is our pleasure today to welcome Dr. Gil Hoftman to the show. He is a child, adolescent, and adult psychiatrist and an assistant professor in residence at the UCLA David Geffen School of Medicine. And he is an avid researcher in the mechanism of cognitive dysfunction and schizophrenia, and specifically at the biological and molecular levels. He has prolific publications on psychosis risk, neurodevelopmental disorders like autism spectrum disorder, neurobehavioral genetics, imaging, neurocircuitry, and neuromodulation. All very exciting topics. So, just to start out, Dr. Hoftman, how did you get interested in researching about schizophrenia?
Well, first of all, thank you for having me on the show.
Sure.
It's a pleasure to be here. And I think, like many other people who are interested in certain areas, whether it's medicine or not, it was a combination for me of personal experiences, curiosity, both intellectually, and then from a physician standpoint, the ability to hopefully be able to help people who are vulnerable, who need some guidance when they're feeling really sick. So, to get a little more specific, I do have extended family members, and I had some close friends who developed, psychosis related to bipolar disorder and also schizophrenia. And even more recently, I had a friend who developed kind of a later onset of schizophrenia in the early 30s, which we could talk about this, but we usually see the onset a little earlier than that. And that was particularly devastating to see. At that point, I was already obviously into the field and interested both from research and clinical care. But ultimately, I mean, I remember as young as, in middle school and high school, hearing about my aunt and my uncle, hearing about times when they were kind of stable on medications, and then how their their behaviors and their symptoms would completely shift once they were off medications, and they would have to me what was both very sad but very interesting experiences. My uncle classically thought that police and intelligence agencies were tracking him and coming after him. He had paranoid schizophrenia. My aunt with bipolar 1 disorder and psychosis would spend weeks on the street at night, dancing, playing music, not coming home, followed by months of not leaving the house, not showering, not taking care of her kids. And the other thing that was fascinating to me is that they're married, paranoid schizophrenia and bipolar 1 disorder. They had 2 kids, which is also not that usual, right? And one of the kids is, incredibly, well integrated, a lawyer, has a family of his own, doing very well in life. Another kid from teenage years has been in and out of hospitals with severe mental illness. So all those things have been really fascinating to me from a personal standpoint, and how something like these conditions can really affect a person's connection with the world around them, both the people and other experiences, is just fascinating to me from an intellectual pursuit as well. So to me, like many others, I think a combination of personal, intellectual, and then also a desire to be able to intervene and help is what drew me to schizophrenia.
Yeah, thank you so much for that. It's really, really a different kind of experience when it's something that personal and close versus from us as practitioners. But that's such a unique and motivating force to go into this.
And I really appreciate you sharing that. I'm sure you see this in a lot of families that, this isn't something that a lot of people talk about or feel comfortable talking about. And, there's still a lot of stigma. And so I sometimes think I have a day full of patients, and each one thinks they're the only person going through what everybody else is going through. And so being able to talk openly about our experiences, about what's going on and what sort of brings us forward and just the human side of what it's like more openly, I think is frankly a relief to a lot of people who might be struggling with this or even starting to think about it.
Yeah, I completely agree. I think the more we talk about experiences openly, the less stigmatizing ideally it will become. And, maybe people will be more willing to also, see people in a different light and not feel so threatened and be able to interact with other folks. I imagine hopefully we'll be able to talk about some stigma because that is a huge issue in psychiatry and in medicine and in a lot of different areas, but particularly with schizophrenia. This has been another major burden that people experience beyond their condition itself.
Yeah. And kind of expanding on that, I think the recent topics of homelessness. And there are a lot of people with a severe mental illness who aren't able to stay on their medications and have persistent support that end up in these areas. And so I think at first glance, it can be very scary, but we do know that people with schizophrenia have lower chance of being violent. Evidence has shown that. So yeah, I think that's such an important thing to highlight.
A lot of the discussion around stigma reminds me, and here I'm dating myself, but for some of our older listeners, it reminds me of, back in the 50s, 60s, 70s, the discussions around breast cancer, ovarian cancer, and things that we don't really know how to help, we're afraid of, and we can't talk about. And frankly, I think for a long time, psychosis fell in that bucket. And there was a worry or a fear that once this happened to someone, especially a loved one, well, there's nothing you can do, really. But now I feel like as we're understanding it more, as the field's advancing, as we feel more empowered around both pharmacologically and non-pharmacologically things that we can do to help, it's a good time to start talking about it more and opening up the discussion more.
Yeah, I completely agree. I mean, I think one poignant example of a condition that was highly stigmatized that has become barely talked about in terms of stigma is HIV and AIDS.
Mm.
That was a killer pandemic. People were scared to even get near another person, which HIV or AIDS, touch them, really shunned because this was such a scary, potentially infectious kind of disease that was killing people and, was targeting initially maybe certain subpopulations of the community. And there was nothing you could do about it, right? But then, with the development of a medication, things started to shift and it took a long time, right? It wasn't just, okay, all of a sudden we have this medication and all the stigma is gone. It took a long time. And it took a lot of iterations of making medications better, of teaching people what this condition is about. I remember all the different campaigns that came out to try to help destigmatize and reduce the fear. And now someone can have HIV, take one pill per day, and live a long life without anyone else even knowing that they have the condition. And that is remarkable. And I think, there are other instances in medicine where this has happened, like tuberculosis, for example, where, people literally used to be isolated and sent to sanatoriums and gotten rid of from the population until we had a way to address it and to treat it. And then people were able to kind of reintegrate into society. So, I mean, this has happened in neurology and psychiatry too with epilepsy. There are countless conditions that people experience that chronically or infectiously that really scare other people and brand them and stigmatize these individuals. The problem, I think, with psychosis and schizophrenia is that there was some progress to help people get out of the hospital, but there was so much residual symptoms and ailments that made individuals unable to kind of reintegrate into society, or they wouldn't be able to maintain their medication because of bad side effects, or maybe it wasn't that effective. So now people were able to kind of come back into society, but they weren't really being getting sufficient treatment to really control the symptoms in the long term. So that's a really, so I think in some ways that continues to contribute to stigma. And that's something that people, for example, with schizophrenia have been stuck with for a long time. Whereas some of these other conditions, you've seen the remarkable changes. And like you mentioned, cancer has been another major change where it was so highly stigmatized and nobody would talk about it. And now there are treatments. So hopefully, as we develop better understanding and come up with better treatments for these conditions, we can also in parallel reduce the stigma, talk about it more, and really just deconstruct the fear that surrounds these conditions.
Yeah. And speaking of fear, I think that is such an important point to talk about, to let people know they're not alone. If they are working with someone with schizophrenia, or if you're a parent or a family member. And I want to kind of talk about like what it's like to work with them and what that interaction is like. I remember, when I was inpatient, working in the inpatient unit at UCLA as a fellow, I had a certain impression of schizophrenia. Mostly worked with adults prior to my child training. And with kids, it's so intense. The presentation progresses so quickly. I just saw firsthand how hard it was for families to like really understand and accept this progression of this disease. And so there's kind of this feeling of loss, such a quick sense of loss that happens. And so I just wanted to ask you about, what do you think it's like to work with people with schizophrenia?
Yeah, I mean, I think it's a highly varied experience, just like with any other condition and any patients that you work with. Each patient is unique. They may have similar symptoms or some overlap in symptoms, but then how the condition affects their life is really unique, and so you really need to take a person-centered approach, right? And not just person, but especially in child and adolescent psychiatry and in conditions that come on neurodevelopmentally. Ideally, you can get the family involved. You can get other individuals who the patient feels supported by involved. You can connect with the school. You can connect with other systems, because as we know, a condition and a chronic condition is much more than the symptoms. And patients, we know, would love to have their symptoms under control, but they want to live their life. If you're treating someone with a drug and you're getting some symptoms under control, but then they have debilitating side effects, or other symptoms that are more debilitating aren't being controlled, and they can't, go to school or work, they can't have relationships that they want, they have all kinds of dysfunction that affects their quality of life. Well, then, are you really treating them? Okay, you're reducing some amount of burden. But so you really have to take, I think, a personalized approach in working with the individual, learning about them, aligning with them, learning about their goals, of course, getting the more acute things under control so that you can then have these interactions, and then involving the people who are supportive, who are part of the unit, so that they understand how to better help their loved one succeed, whether it's the way they talk or interact,
Mhm.
how they conceptualize the different symptoms or the different behaviors. The whole goal is to provide a supportive and therapeutic environment so that the person can get back to their life. But you're right, this is a very scary situation for a lot of people, especially in this, kind of first episode or at-risk state, because a lot of people don't know what's happening. And we ourselves can't often, mostly can't predict what will happen long term, right? In the psychosis risk phase, for example, people come in and they have subthreshold perceptual disturbances, thought disturbances. And then in the studies, only about 20 to 25% of those people will actually develop a full-blown psychotic illness. So the vast majority won't. So even sharing that with patients and their families can already give some room to breathe and say, okay, well, I'm not doomed. actually the chances are I will not develop a full-blown psychotic illness. And so then, when we talked earlier about homelessness, what that brought up in my mind was almost like kind of a wheel of dysfunction or a wheel of issues. And, we think about psychosis, schizophrenia as positive, negative, and cognitive symptoms, and we could get into that. That's the psychosis symptoms, like delusions and hallucinations. It's also the symptoms that cause, withdrawal from the world and affective flattening. So can't express emotions, can't have social interactions. And then cognitive symptoms, where you can't even keep in mind, a conversation that's going on, or your processing speed is so slow. Good luck working and staying on top of school or working. So how can you function when you have those kinds of things happening? And when it's starting to unravel, that's very scary, right? So, what I think what's important is to, bring people in to help them understand what might be going on, right? And then to help treat not only symptoms, but also comorbidities, right? So this wheel of dysfunction that I was starting to talk about, oftentimes, we think of symptoms, but there are a lot of comorbidities. One of the key comorbidities is substance use and different types of substance use, right? And that could be very difficult, in terms of both treatment and functional outcome. And so if someone is having these symptoms and comorbidities during adolescence, for example, or very young adulthood, then you can imagine it leads to educational struggles. It leads to impacting personal relationships. And if you're having, social relationship and educational struggles at that time, well, then how are you going to establish, these key relationships that will give you personal and professional satisfaction during your adult life? So it could lead you to unemployment or underemployment. And then when you're led to underemployment or unemployment and you're isolated, that's when you're at risk of becoming homeless or losing shelter, right? And to me, and then, you become homeless, you're losing shelter, you become vulnerable to attacks, to violence. There's this wheel and cycle of, going from homelessness to hospital to jail, to homelessness to hospital to jail, which is devastating. At the end of the day, I think the saddest thing is that then it leads to reduced life expectancy. And the latest data is showing that the reduced life expectancy is about 30 years in the US. That is not subtle. So if your average life expectancy is 78, for example, someone with schizophrenia will be expected to live to about 48, 49.
Mhm.
So that's, so you think about all these types of things and you think about the critical period of development. And so I think the biggest thing, honestly, in working with families and patients with the early onset or like kind of the early aspects of this illness is basically providing, education, reducing fear as much as possible, treating comorbidities, and providing a therapeutic environment that's safe, that people will want to come back to if they need it, right? Engagement, I think, is the key.
Mm-hmm. Yeah, and I really appreciate what you're saying about it's really compounded. These risk situations are piled up on top of each other. When you mentioned substance, it did bring to mind cannabis use, which I think has been such a fairly hot topic for a number of years now, especially with a lot of the latest research on extensive adolescent use and increasing the risk for later development of schizophrenia. Do you have thoughts about cannabis use and schizophrenia?
I have a lot of thoughts on this. Actually, as part of my PhD, we studied potential biological plausibility of cannabis use during adolescence and impact on neural circuitry. So that's from the neuroscience standpoint. I mean, I think from the person standpoint and epidemiological standpoint, no matter how hard people try to kind of control for factors that may be influencing the relationship, we can't seem to get rid of that association between cannabis use during adolescence and increased risk for psychosis. And at the highest levels, it's about eightfold. But in more recent meta-analysis, it's more like between 2 to 4-fold. And that all depends on the timing. So the younger you are during adolescence, like 12 and 13 versus 16 or 17, the higher the risk. The potency of THC, the higher the concentration of THC, the higher the risk. And we know now with legalization here in the US and the different types of cannabis strains, people get very high potency THC, which is cannabis, which is very different from what people used in like the 60s or 70s. Okay. And then the third thing is the dose, right? So people who are heavy users, typically heavy daily users, multiple times per day, are at highest risk. I think all those things also need to be combined with some kind of genetic liability or genetic risk, because there are folks who, do this with all three of those components who will not develop psychosis or schizophrenia. So I think that there's a combination of those environmental factors with genetics that then ultimately put someone on the path. But the point is that you can't really predict that. So if a patient's coming in to see you, first of all, if they're coming in to see you and they have any sort of, symptom happening, whether it's psychosis or not, well, then they might be vulnerable. So it's probably best to advise not to use ideally, or to give some advice about how to use in the most harm reduction way possible. Yeah.
Tangential thought. One thing that I've noticed as we're talking, and I think we do get used to it and thinking about it differently, is that we're sometimes using almost psychosis and schizophrenia interchangeably, I think, in our discussion, and schizophrenia symptom disorders, and there's quite a history. So depending on when you've been looking into this, or sort of where you learned about this, I think people will have very different ideas of what those terms mean and how they're related to each other. So if you could just help us, from someone who sees this every day, how do you think of those two words, concepts, and how they're related?
I think that's a great point. I think early on, when we're studying psychosis, we tend to use psychosis because schizophrenia itself is a chronic condition that has to be present in most cases for at least half a year and has multiple components to it. So psychosis tends to be the positive symptom aspect, but then in schizophrenia there are also what's called, as I mentioned before, the negative symptoms and the cognitive symptoms. So early on, if someone is having disturbances in thought, disturbances in perceptions, these are things that will end up becoming delusions. If someone develops schizophrenia, or in perception will become hallucinations, or they're having unraveling of their associations, then we start to think about that as psychosis in the early phase, because we don't know if the psychosis is going to be chronic, short lasting, long lasting. Psychosis itself, to me, the way I understand it, is really, a disturbance in the faculties of your brain. So it's almost like a loss of homeostasis in terms of the integration of thought and mood centers of your brain. And in fact, what's interesting about that, here's a little tangential tidbit. In Japan, they've actually changed the term schizophrenia, which is highly stigmatizing, to integration disorder, because they see it as an integration issue, not as multiple personalities, not as splitting of the mind, but it's the splitting of the integration of different neural centers. So, I think, psychosis can occur in anything that disturbs the homeostasis of your brain or the balance of your brain. That could be substances like drug use, right? Like amphetamines. It could be medications like anticholinergic medications that could cause delirium, for example. It could be brain cancer. It could be seizures. It could be all kinds of neurologic, metabolic, anything. It doesn't have to be schizophrenia. It doesn't have to be psychiatric at all. It could be autoimmune that attacks your brain too. So psychosis is really, it describes a cluster of symptoms where the brain is kind of not integrated. And so people start to lose touch with the shared reality of other folks. And they make associations that are different from what most of us experience on a daily basis. But that psychosis can then be a component of schizophrenia, which is kind of a longer term and multifaceted condition. And I should say, the other thing that we also often talk about is schizophrenia as though it is one component, one disease, one disorder. the reality is, historically, people have called it the group of schizophrenias. And perhaps biologically, we will see multiple different biological causes or drivers that lead to these final common pathways that we call schizophrenia. But it could end up being multiple different pathways, just like breast cancer, right? You can have multiple subtypes of breast cancer that are then targeted by different treatments. We all call it breast cancer, but there are multiple different biologies that lead to that. And so it's possible that we'll see the same types of things happening for things like schizophrenia once we better understand the biology underlying it.
I think that's one of the most interesting and simultaneously frustrating things about our field. We don't have the X-ray where, you break your arm, you see it on an X-ray, it's a broken arm. We know what to call it. So we sort of take and put things together in ways that make sense. And sometimes we get new information that causes us to change how we categorize everything. What that brings up to me, and I'm asking the right person about it, is the relationship or lack thereof, depending on the time frame, of autism and developmental disabilities and schizophrenia and psychosis, and how it used to be sort of juvenile schizophrenia, and then things change from there. So I'm, for context, a bit of a history nerd, and I sometimes go too deep into this, but if you have thoughts about that, I would love to hear it.
Yeah. I also love history of medicine, history of psychiatry. I mean, I think, to know where we're going, we need to know where we've been and how things have been kind of built up, right? So as a history buff, you're probably aware that the term autism was coined by Eugen Bleuler when he was describing schizophrenia. And one of the core negative symptom features was autism, right? And this was basically like a disturbance in language and in relating to other people. They noticed that in schizophrenia, people would basically withdraw, or they would have odd, responsiveness to other people, or, maybe a lack of responsiveness to other people. And, so this term really comes from trying to conceptualize the negative symptoms as we know them now of schizophrenia. But as time has gone by, right, as we were continually reconceptualizing, especially diagnostically or categorically, what these conditions are, we're now at the DSM-5, where we see things more as a spectrum, right? Which makes sense. I mean, there's in any sort of particularly chronic condition, you're going to have a spectrum of severity, a spectrum of combination of symptoms, whether you're talking about diabetes, heart disease, or schizophrenia, right? So it makes sense. But now, we have autism spectrum, we have schizophrenia spectrum. And to me, a lot of symptoms are shared between these two conditions. It's more of a question of what's not shared. And I think really the key things that are not shared or, continuously excluded in autism are the psychosis, basically, the delusions, the hallucinations, the thought disturbances, loosening of associations, right? So most of the other kind of aspects tend to overlap, in one way or another. And so, so it's fascinating because then if you look at it genetically, and folks are studying genetic and neuroscientifically, there's also a lot of overlap genetically between a lot of conditions in psychiatry, but also between autism and schizophrenia. We're seeing a lot of overlap genetically in terms of copy number variants, in terms of rare genetic mutations, even in a number of common variants. And these are, I'm using terms, these are different types of frequency of genetic types of mutations and different types of genetic mutations that are seen in the population. And so some of them do have functional consequences that we know of, and others are probably more subtle. But when we look more and more at the genetics and at the neural circuitry, we do see a lot of overlap. And this is also another term that we call pleiotropy, which is basically the same genetic risk factors occur across multiple conditions. So you can have gene X that is causing an increased risk for bipolar disorder, schizophrenia, autism, intellectual disability, and that's pleiotropy. So that's also what makes it very difficult to deconstruct in a mechanistic way what might be happening in condition X, Y, or Z. So I think, in terms of autism and schizophrenia, I mean, I think there is a lot of overlap, and people have, in some ways kind of tried to conceptualize it as maybe kind of more severe disturbances early on in homeostasis of the brain or development of the brain versus, different types of disturbances later on in, development of the brain. But with neurodevelopmental conditions, I think you could see all kinds of different symptom clusters and effects on function depending on when it happens, what genes are affected. And so, I study a condition called 22q11 deletion syndrome, which has very high rates of autism, schizophrenia, intellectual disability, anxiety, ADHD. And so, do you diagnose someone with 22q11 deletion syndrome with 5 or 6 different psychiatric conditions, or do you conceptualize it as, a pervasive, what it used to be called, but a pretty severe neurodevelopmental syndrome that's just causing all kinds of developmental changes that lead to all kinds of different cognitive, thought, and emotional disturbances?
I don't mean to take us off topic, but I did my training at Hopkins, and they have a psychosis unit. And the attending used to say, for any given 20 patients on the unit, 3 of them have that condition, just undiagnosed.
Right. So true.
I'm reminded of, again, this I think in one of your papers, you were talking about the level of penetrance and how all of these different risk factors genetically, it's not something to totally freak out about, but it's not something to ignore. And that you really have to stay with the person and observe and gather data and really be patient about this process. Because as you said, there's a lot of people who don't develop full-blown schizophrenia, and yet it's not something to be completely dismissed.
Yeah, absolutely. Yeah, I agree with you that we really need close monitoring because, one of the other things about this at-risk state, for example, is that one possible outcome is conversion to full-blown psychosis or development of schizophrenia, right? But that's clearly not the only outcome. There could be all kinds of outcomes. People with these kind of subclinical symptoms have comorbidities often, and there are other things that are occurring in the background, like trauma, for example, is a big one. So just because they don't develop psychosis or schizophrenia doesn't mean that they go back to full healthy functioning. They can have all kinds of other types of symptoms. They could develop mood disorders. They could struggle with complex trauma symptoms, and some people actually do remit their psychosis their subthreshold psychosis symptoms and actually do very well. I think that's another point that I really do want to emphasize in our discussion is the strengths and the fact that this is highly varied, just like any other chronic illness, chronic condition. And there are many people living with schizophrenia who are highly accomplished, who you would never know have schizophrenia. But we're so used to, seeing maybe patients who are very severe. It's kind of like borderline personality disorder also. You see borderline personality disorder in the hospital and you see the severe forms of it. And you think that, oh my God, anyone with borderline personality disorder cannot function in society. But the reality is the vast majority of those people can function and function pretty well, but, have crises, have issues that come up. With schizophrenia, there are a lot of folks out there who are just functioning very well, doing very well for their life. And so we also have to, I think, recognize the strengths that individuals still have, that they are not defined by their condition, and that there are all kinds of structural issues in our society and stigma that keeps people stuck and keeps people from succeeding. And I have a colleague right now, at UCLA, who's part of our lab, who is absolutely incredible, brilliant, and has struggled with psychosis. And so, people, and obviously we've seen books written by obviously very amazing people. But the point is that this is not an exception. This is not an exception that people with schizophrenia can function and do well. That's actually part of the stigma, thinking that, oh, if someone has succeeded with schizophrenia, then they're a special case and we need to discard it because that's not the reality. So I think it's important. I know we talk about, obviously we want to help people, we want to focus on symptoms and things that are impacting their life, but we cannot also ignore the fact that they are people with inherent strengths and resilience, and can be very successful.
And I think that is one thing that families and patients are frustrated by, both the sort of sense of doom that traditionally accompanies a diagnosis like this, but also the difficulty of recognizing the condition itself sometimes, because the thing you're using to look at conditions is what itself has a condition. So,
Yeah.
for families, helping somebody who doesn't fully recognize what's happening or what's going on or have insight into it. And for patients, the fear of the ground shifting out from underneath you and not knowing where to turn, or how to even recognize when things are getting worse, and learning how to sort of catch that early. So this could be, an entire career's worth of learning, but in 10 words or less. Do you have any thoughts or advice for patients and for families in terms of sort of how to help, or how to manage this, or how to seek care, or how to help somebody seek care who maybe doesn't recognize that something's happening?
Yeah, I mean, I think one thing is to recognize that that is a symptom. So there's a fancy word for it, anosognosia, that it's symptom blindness or inability to recognize that you have an illness or symptoms. And I think, if people, family members, other folks who are interacting with someone who has this symptom, recognize that it's not the person being stubborn, it's not the person being difficult, it's not the person behaving in a way to try to, make your life difficult. It's actually a symptom. That's one way also to kind of reframe that in a caregiver's mind. So then once you understand that, then maybe you start to think of more creative strategies of how to connect or how to interact. Sometimes, for example, if it's a fixed delusion, there's no way you're going to convince someone that it's not real, right? I mean, this is their experience. It's real for them, So that's something that family and like practitioners who are interacting with these people should get out of their mind. It is real, right? So how do you try to treat that? Well, people's experience can lead to anxiety, distress, lack of sleep, all kinds of impacts functionally. So I think if you focus on what the person's goals are, and you kind of try to connect how those goals are being impacted by the distress, the stress, the anxiety, the lack of sleep, then maybe you can help them target those types of symptoms without saying, hey, you have psychosis, you have delusions, like your experience is just so bizarre, like I don't know what to do with you. But no, these people need to sleep, they need to not feel super anxious or distressed. So sometimes reframing it in those ways can really be helpful for the patient and for the family. Sorry, by the way, that was more than 10 words, but I'm trying to keep it.
But each word was precious, so
Yes.
it was very worth it.
Yeah, it's like subwords under each word, right? Yeah. Yes, the goal, asking them about their goals, that's so, so important, because I think it really humanizes them. We all have goals. We all have things we want. That's just human nature. And I remember when I was working with a kiddo with psychosis, and she was feeling like her classmates heard her thoughts through like the radio, and we hear that a lot. It's a kind of this classic thought broadcasting kind of symptom. And, instead of focusing on that, asking more about what scares you about that? What is it about that affects you? And then she started talking about, well, sometimes I have bad thoughts and I don't want to hurt them. And I don't want my friends to know that I have these thoughts, because I love them and I want to stay friends with them. And so the goal is to maintain friendships. But the symptom is telling her that she can't. And so there's this kind of like internal suffering that is going on because of the symptom. And to have conversations surrounding that destigmatizes, their experience, and I think really helps families understand where they're coming from.
Absolutely.
Yeah. You mentioned about trauma. I wanted to go into that a little bit because the a lot of psychosis symptoms can come from trauma too. And we've had the ACE study that's come out and said that a lot of early childhood adverse experiences can really impact your physical health as well as mental health. And so I wondered what you thought about when people first present with psychosis. What do you look for that might suggest a traumatic experience like PTSD, then manifesting in paranoia and psychotic symptoms?
Yeah. I mean, I think, when someone comes in and maybe they're concerned about perceptual changes or changes in their thought experiences and patterns. And I mean, I think you really just have to do a comprehensive evaluation. I mean, you would with any patient, but I think these symptoms can come from anything. So I mean, when approaching trauma, also, right? These are very difficult topics for people to talk about, especially children and adolescents. So I don't try to force anything, right? I just try to really engage, build trust, make sure that people know that I'm aligned with them, trying to understand what they're going through, and trying to see, what might be troubling them, or what might be contributing to their experience that brought them in, right? So, I guess it's, for me, you ask about things, you gauge in a very open and inviting and non-judgmental way, what the individual feels comfortable talking about, what they feel comfortable sharing, and this becomes kind of a longer term process. So so I'm not necessarily looking to get all that information in the first encounter in the depth that I need, maybe to understand what's going on and what's driving any of the symptoms, but let's say the psychosis-like symptoms or the subthreshold symptoms. But really trying to get a better sense, and over time getting a better idea, unless this comes up naturally, right? Or unless they are answering it and going into it, and then you can explore further. But I think it's something that everyone should think about when they're evaluating someone with subthreshold or psychotic symptoms. You have to think about trauma, and trauma in all different forms, and when it may have occurred, if it's still occurring. That has to be a critical part of the evaluation.
I think it speaks to the complexity of patients in general, but particularly patients with these types of symptoms. And, I think sometimes I don't know if error is the right word, but sometimes if people identify one thing, they stick with that one thing and don't reevaluate or sort of look deeper or look more broadly, especially if that's something that they know. So a trauma expert may see the trauma and delve into the trauma and do sort of intensive, prolonged exposure on somebody who has flagrant psychotic symptoms, who can't tolerate that, or somebody who's treating psychosis with medications and taking more of a biological approach might miss deep trauma etiology. So having sort of a broad view of really conceptualizing what's happening and where it might be coming from.
Yeah, it's almost like a premature closure when going through diagnosis, right? And I mean, I think it happens to everyone, but it is something that I think is important to keep in mind, and to keep thinking about, and not that every person is a nail if you have a hammer, right? But really trying to just critically think and get new data and new information from the person to try to best help them, really, at the end of the day, right?
I often get, people that come in and they have Googled the diagnostic criteria,
Oh, yeah.
DSM-5 criteria for schizophrenia or whatever other severe mental illness. And they say, okay, this is happening, so I have it. And it really speaks to how important it is to really see someone who's specialized in the full psychiatric assessment and evaluation. So I think that's really important. So maybe we can move into a little bit more of the treatment approach of more specifically schizophrenia and schizophrenia spectrum disorder is very, very multidisciplinary team-based approach. And so we have the medical team, we have the therapy team, including individual and family therapy, which encompasses a lot of psychoeducation. I think that's such a key point in the treatment, and also psychosocial interventions, specifically skills learning, occupational therapy, support groups for families, peer support. So there's many, many layers of the treatment approach. And I wondered what you thought about that, Dr. Hoffman, how you approach it.
Yeah, I mean, I think it has to be multifaceted, integrated, because again, as we talked about earlier, treating something like schizophrenia, which is, we know it's chronic, is much more than just treating the symptoms, like the psychosis, or if we are fortunate enough to be able to touch and improve the negative and cognitive symptoms with medication or with therapy. So great, that is very important, right? Because oftentimes symptoms get in the way of allowing people to function. But even if you turn down the gain on the symptoms or treat some of the symptoms but not others, the person still wants to live their life, right? They want to have some sort of meaning, and most people don't want to just sit around and do nothing all day or be isolated. It's usually something that's driving them to isolate or kind of stay internalized. And so, yeah, so you need to have teams. You need to have teams that are, helpful in terms of getting people back into school if they're at that age, or getting people back into work. But it's not just for the goal of getting them back to school or getting back to work so that they could be productive. It's really first figuring out, what is your goal? What would you like to do? Let's say you didn't have any of these issues, or maybe even with these issues, what do you want to do? What makes you feel like, positive about life, or feel like you enjoy? And that could be also hard for someone to identify at first. But if you have, skilled individuals who are helping them come up with this plan and doing it over time, then most people can identify things that they enjoy or have value or meaning to them. And so if you can then craft a plan with the individual and with their loved ones to help them get closer to those goals and values, well, then that, I think, is the most important thing in this whole treatment process. So maybe in order to, do their artwork, they do want to still do some art classes, or they want to build their own little small business, or go work with a group who does artwork. Well, then maybe they need certain skills to develop that maybe they couldn't because they were ill, or maybe they partly developed. And maybe they need those skills to be able to then achieve their goals. So, I mean, to me, it always comes back to, what does the person want out of their life, or more immediately, like what would they enjoy doing on a day? It doesn't have to be this grand like purpose or goal, but just, small goals. Like, what do you want to do? How do you imagine your day going, and it being a good day? And so, and anything you could do to build the teams around that to help people achieve that. And so, for example, one thing that some folks do is they do mock interviews, or they prepare people for job interviews, because that could be very anxiety provoking, and they may have trouble knowing kind of what to say or how to react to certain situations. Or so even doing mock interviews and helping people know what that process is going to be like can be very instrumental for them getting that job. But then once they get the job, they also need help to sometimes learn how to keep the job, and how to interact with folks, how to manage stressful situations, how to ask for maybe some time off if they need, so they don't lose the job, but they can, kind of manage whatever's bothersome. So to me, yeah, that comprehensive care is absolutely essential.
And I would imagine that part of that discussion of people meeting their goals, it will at some point, and treatment in general will involve a discussion of medication. And I think sometimes there's an idea that maybe the side effects of the medication, or having to take a medication every day, may actually get in the way, or people might report that they feel stinted or less creative or something. So
Yeah.
how to build that discussion in with what you're talking about.
Yeah, the medication piece is a big challenge. I think there is some data that about 3/4 of individuals with schizophrenia who are taking an assigned antipsychotic will discontinue within a year and a half. And that could be for a number of reasons. Side effects are obvious. But even sometimes if people feel a little better, they're like, oh, well, I don't need this anymore. Or sometimes if people don't have insight or feel like they were kind of forced to start due to their circumstances, and they're like, well, there's nothing wrong with me anyway, so why am I taking this? Sometimes it's just hard to, like you said, keep taking a medication every day, whether it's once or more than once per day. So there's beauty that we do have long-acting injectables that can help alleviate some of that burden as long as the person is willing to have an injection. I think that needs to be a conversation. But still, the medications come with a lot of adverse effects, and it's very difficult for people to continue to take them. So inevitably, like I said, the vast majority of people, especially after a first break, will at some point go off of their medication. Ideally, hopefully, we will be, discovering new mechanisms, coming up with new types of medications that, maybe are more effective ideally, but even if they have same efficacy, maybe have a different side effect profile. And I do want to mention that recently, you guys may have heard, there was an FDA approval of a new type of medication, which is a muscarinic agonist. It targets a different neurotransmitter system than the dopamine system that most of the medications have targeted to this point. And the medication is a combination of two cholinergic type drugs, and it needs to be used in the real world to see how it does. So, there's a lot of promise now, and the studies looked very good, but we need to make sure that it's tolerated. The one issue about it is you do have to take it twice a day. So that's one issue. But the one huge difference right now is that because of the mechanism, this medication does not cause movement-related side effects. It does not cause metabolic-related side effects. You don't have issues with hormonal regulation, issues with weight gain, issues with diabetes or heart disease related to the medicine. You don't have issues with movement disorders like stiffness or too much movement because of the way this medication works. It's right now it's called xanomeline trospium, which is a combination, and the new brand name is called Cobenfy. It is pretty monumental. It actually got FDA approval 35 years to the exact day that clozapine got approval in 1989.
Wow.
So it's like the first major new FDA indication for a new mechanism of treatment for schizophrenia in a long time, even though obviously other medications have come out since then.
One thing about that medication and similar medications is that it's approved for adults. So for children and adolescents and parents especially, not to go into all the details of the FDA approval process and how that works, but how concerning is that if something is approved in adults but not in kids? I'm sort of begging the question because we use them all the time, but how commonly do we use those agents in children, and how concerned should parents and patients be about that?
Yeah, I think it is concerning. I think, it's approved in adults, but we see the medications that are approved in adults that we then extend to children and adolescents have different effects. The side effects are different often. It can be worse in certain ways. Maybe the medication itself is not as effective, for example. So I think there will be multiple steps in terms of learning about how this works and how effective it is, and then seeing if it makes sense to introduce it earlier. I will say the one thing about, for example, the psychosis risk state in mostly in adolescents is that many psychiatric societies across the world, based on the data, recommend that you do not prescribe or use an antipsychotic medication to try to prevent transition to a full-blown psychotic illness or episode. So if you're seeing, some perceptual abnormalities or some thought disturbances that's making you worried that, okay, this person may develop a full-blown psychosis, whether it's schizophrenia, bipolar disorder, or something else, that is not a reason to start prescribing an antipsychotic for them to prevent that conversion. There are reasons to prescribe the antipsychotic, right? If you're using some of these as a mood augmentation, mood stabilizing type of thing, and because you have thresholded symptoms, you actually have the condition, then sure. If you're using it to try to prevent behaviors that are damaging to self or aggression, things like that, sure, you should use it. And then if they have full-blown impairing psychotic symptoms, of course, right? So I thought I would mention that because that's something that people often aren't sure about. And the best data that we have worldwide now is suggesting that you should not do it because it just puts people at risk for side effects. And it's unclear, even in a small subpopulation, whether it would be helpful.
That's so important to mention because that first impression of a medication is crucial for patients. I think if you already are not sure about taking this, you finally agree, and then you take it, and it has this awful side effect, you never want to touch it again. And so speaking to kind of this building of trust between your psychiatrist and you, that's also a good protective and good prognostic factor that we want people to know we really care. We're putting their best interest in mind, and to continue to build that trust of looking and examining this together, that it's a collaborative approach.
Absolutely. Yeah. First impressions are critical.
Now we're fortunate to be in Los Angeles, all of us, near, multiple major academic centers that are looking into this, that are doing research, that have clinical arms and clinical wings. Even then, there are wait lists and barriers to getting into care, especially that degree of subspecialized care, but not everyone lives in that area. So if parents, patients are looking for more information on these topics or to find care, do you have typical go-to resources? Do you have places that you refer people to look at? Because the internet can be a dangerous place for good quality information and how to find help.
Yeah, it's a very challenging situation, definitely. I mean, there are support groups like the National Alliance on Mental Illness, NAMI, that also has a bunch of resources that try to connect families and try to help patients find resources. There are also I think the National Institutes of Health have some sites where you can also look, and they can provide some resources, some information. Overall, though, a lot of it does end up being referrals, and so that's the hard thing, access, right? Because then people who are in resourced areas, who are connected with practitioners, who then know the different resources that are available, end up getting access to those resources. Whereas people, obviously, who do not end up kind of being left behind in a way.
Yeah, and I think just, our primary organization, the Child and Adolescent Psychiatry, ACAP, American Academy of
Right, ACAP, yep.
Child and Adolescent Psychiatry, we do have facts for family sheets that tell families about what these conditions are.
And I will say that each state, no matter where you live, has one or multiple ACAP local branches. So one thing that parents can look for is their local ACAP branch. I'll get cold emails, cold calls, not that infrequently, from people just sort of looking to connect to care. And, I'm fortunate that I know different resources and different ways to find it. But even outside of that, pediatricians often either have or can find good connections.
Right.
And we talk about this because there aren't, I mean, let alone this degree of subspecialization, there simply aren't enough child and adolescent psychiatrists to go around.
Exactly.
So access to care is a real concern, but I think that that's something that we're working on at our level, of course, and the organization's focusing on. But I think
Yes.
encouraging parents, patients, not to get discouraged and to try to reach out as much as possible, because I do think sometimes with a condition where you're worried about seeking care and then care is hard to find anyway, that there are so many barriers to getting good evaluations for something like this.
Yeah, there are a lot of barriers. The other thing that just came to mind is that SAMHSA, SAMHSA, which is the Substance Abuse and Mental Health Services, part of the government, has behavioral treatment locators also, that can try to help you find it. The problem with a lot of these things, including like Psychology Today is another resource, is that you then get inundated with a lot of information, and it's hard to kind of pick out who you think might be specialized or might be able to help. So that in and of itself can become a barrier because there's almost like too much information to look through and you don't know who. So I think it's important, maybe like you said, the pediatrician or another physician provider that you have, to kind of help you work through that if there's some concerning symptoms. There is another, I haven't looked at this in a little bit, but there is another institute called the LEAP Institute, and they're highly focused on trying to address things like anosognosia, and address like actual helping family members learn how to interact with others. So it's LEAP Institute. So there are different kinds of resources like that can also potentially be helpful, even though those are not like direct resources to help you get connected with, your child and adolescent psychiatrist, who might be, seeing patients with a condition that you are trying to get help with.
Great, great. Any last thoughts or words, Dr. Hoffman? I mean, it's been really, really refreshing to talk to you. I think you just give a very big picture research and systematic kind of view, not just honing in on one thing. And you have a way of communicating where you focus on the important stuff. Sometimes we can get bogged down by the details and the genes and the this and that and this and that. But I think it's so important to keep a bird's eye view of like what's important in this population of people. So yeah, any last thoughts?
Yeah, I mean, I think the big thing is just really to keep the hope alive, that there are really good outcomes, that, people can have also periods where they're really struggling, but that period doesn't have to define the rest of their life. A lot of people experience, shame and guilt for how they were when they were experiencing psychosis, and that comes with stigma. So anything we can do, especially as doctors and other healthcare practitioners, to help the person, keep that hope alive and keep going, and focus on, the strengths while addressing the challenges, I think is going to do the best for our patient.
And I also like the collaborative care model that you introduced, and sort of patient focused care, because I do think many people are almost afraid to go into care because they're worried they're sort of surrendering their decision making to a certain extent. And the first thing that's going to happen is someone's going to walk around the corner with a needle, and then they're going to get admitted, and then they lose all their autonomy. So the idea of working with people to find out their goals, intervene early, maximize function. I don't want to put words in your mouth, but that's at least what I took from it. Is one, refreshing, and I think two, very anxiety relieving for people who might be looking for care.
Thank you. Yeah, I agree.